Okay, everyone, welcome back to ICU. Today, I'm really excited. We're going to be talking about mast cells and histamine and all the things with Dr. Theoharides. I hope I said that correctly.
Perfect.
Welcome. Welcome to the show. We are so happy to have you here.
Thank you very much. This is very exciting because I really care about people that have this problem and related problems. So anytime we can help anybody, it's a plus. Yeah. So just a quick about me. I was born in Greece. I was fortunate to get a scholarship as an undergraduate at Yale University back in the 60s. And then I loved the place. I stayed there and I got my bachelor's, 2 masters, my PhD in pharmacology and an MD from Yale. And then went to Tufts University in Boston, where I started the Department of Pharmacology and did training in internal medicine at Yale Medical Center. And I did all of that for a number of years, meaning about 35 years. And now it's been a year where I'm down in Florida, where I'm a professor of the Institute of Neuroimmune Medicine at Nova Southeastern University. And I've been charged with creating a Center of Excellence for Neuroinflammation Research, which is actually quite relevant to what we will talk about today. So,
yeah, that's an amazing career you've had so far. And you've been doing so many amazing things for the interstitial cystitis community. And I was watching an interview that you did with Marnie Glavin, where you were talking about how many research studies you participated in and published. Do you know the rough number?
Yes. I try usually to shy away from that. So I have published actually 480 peer-reviewed papers in PubMed. Stanford University every 2 years creates a list of the most cited physicians or researchers. So I've been included in the top 2% of scientists most quoted worldwide. And there is an organization called ExpertNet that uses data from PubMed to indicate experts in particular diseases. The actual link is Expertscape. And I've been listed for the last few years as the top researcher on mast cells in the world. So. That's
amazing. And did I see your website was called mastcellmaster.com?
That is correct. It was a rather corny name, but it's done its purpose. Thank you. What I'm trying to create now is a somewhat simplified website that might create and provide sort of rubrics for both colleagues as well as patients, because it's so difficult to navigate in terms of diagnosis, in terms of diagnostic codes, in terms of treatments, etc. And there are a lot of, unfortunately, pieces of misinformation that derail everybody. And hopefully, depending on your questions, I might take the opportunity to talk about some of those, unfortunately, roadblocks.
Yeah. Do you want to start off with that, or do you want to get into it later?
No, I'll get a little later. But okay. Suffice it to say 3 things to start us off. Number one, many of the diseases we're dealing with in the last 20 years are not what I used to call bread and butter of medicine. So we have conditions that are complicated, they're multi-organ, and many times they're comorbid. So take interstitial cystitis. But then we have chronic fatigue syndrome, fibromyalgia. All of these things happen to often be comorbid in the same patients. And we used to say that if someone has the propensity for allergies, we used to call it atopy. So if you're allergic, yes, we can skin test you or measure certain immunoglobulin E molecules. But if you're atopic, that means you respond to stress, to odors. There's no allergy there. And now we have the even more broader indication of mast cell activation syndromes that are even broader than that. And many of these play into the particular diagnosis, such as I see. But most of my colleagues really don't understand the connections, and therefore they find it very difficult to come up with treatment approaches as well. second point is that in all of these and many more diseases, we have inflammation, but we use the word inflammation, unfortunately, indiscriminately. So if you've got, passing your finger because you got a thorn in there, that's inflammation, but that's different than inflammation in your skin, which is psoriasis, inflammation in your lungs, which is asthma, inflammation in your brain, that is multiple sclerosis. So we should not be using the word inflammation in general, because the molecules that are involved in each type of inflammation are different, and they're different in the bladder as well. And the last part is that we, among few people, have been proponents of neuroinflammation. So the brain, through either its long nerves, such as the vagus nerve, or local nerves, let's say in the bladder, talk to the immune cells, and we will talk about the mast cells in particular, and vice versa. So if the immune cells are firing, then the sensory nerves can be hypersensitized, and then it creates sort of chronic diffuse pain. And whenever we talk about pain, which is very relevant to IC, we have to distinguish between the precise sharp pain of, let's say you have a needle pricking your finger. We know exactly that that pain was on that finger, versus the more generalized diffuse pain. Sometimes we call it neuropathic pain, because that type of pain can move up and down the spinal cord about 3 vertebrae, 3 levels. So you might have irritation of nerves in the bladder, but you might feel the pain in the higher abdomen. Or you might have endometriosis, and you might feel the pain in the bladder, because that kind of pain moves up and down. And the approach to that pain is very different than the sharp pain that we might get, if you have rheumatoid arthritis, or you have gouty arthritis, or you got trauma, etc. So as we talk about IC, whether we're talking about drugs or supplements, etc., I will try to refer to these 2 different types of pain because they're treated differently. We've got to recognize them, otherwise we'll be spinning our wheels.
Yeah. I mean, you saying that about the pain, I think, is going to be really helpful for a lot of the listeners, because I actually talk to a lot of people on a daily basis who can't really put a finger on where they're feeling pain, but they know that they're feeling pain, and that can be really frustrating.
Absolutely. Besides, over the years, urologists have tried to redefine criteria for interstitial cystitis, because, as you know, we call it interstitial cystitis / bladder pain syndrome. But about 20% of the people, according to urologists, don't feel pain. So should we be calling it a bladder pain syndrome? I think it's much more common to feel pressure in the lower abdomen, and of course urinary frequency, but not necessarily sharp pain. But if you start talking to individual patients about pain, they do hurt. It's just that the description of the pain is different. And again, we shouldn't necessarily discount someone if someone says, well, do you really have sharp pain? They say, no. But then when you start digging into it, of course they have pain.
Right. Yeah, that's a great point. I mean, it could be a burning type pain. It could be sharp. It could be like an achy type pain.
Correct.
Figuring out what you're feeling is really important.
Right. And the pain might be provoked by things that other conditions are not provoked by. So it's also important to ask, what brings up the pain? Is it really that you want to go to the bathroom? Is it because you're stressed? Is it because you're undergoing a viral infection? All of these things, as we will expand on a little later, do actually affect all the symptoms, not necessarily just the pain.
Mm-hmm. And then throw in all of those overlapping conditions, and it gets even more complex.
Right. I often say, and I've said that before, and I say it again, I actually give this piece of advice to patients, and my colleagues might hate me for that, but I tell them, especially if they're women, don't look nice when you go to see a physician. Look as horrible as you are when you feel the pain that you feel, and start with 1, 2, 3 at the most critical symptoms, like your top symptoms. Don't give them a laundry list of 20 symptoms right through the door. They're not going to believe you. You look nice, you have 20 symptoms, you're crazy. And that must happen numerous times. So, you need to capture the physician's attention first, And then you can expand on it, whether it's the first visit or the second visit, but get through the door. Let them believe you first. And then you obviously move on. And of course, many specialists, I don't want to stay just with urologists, clearly have been taught to pay attention to their discipline. And many of them, unfortunately, don't think globally about a patient. It's like outside their area of comfort, if you wish. But I'll just remind everybody, one of the major physicians in the history of the United States had said that a good physician treats a disease, the great physician treats the patient who has the disease. That was Dr. Osler. And it's true. And we're moving away from that. I mean, I've been in medicine for 40 years in the United States. I've gone through very good medical schools, etc. And we used to sit around a table and discuss the patient. Now insurance companies don't even pay for the time to bring 3 or 4 people together. And that even for the simple diseases, let alone the more complicated diseases. So we have to change the whole mentality of medical school all the way through the societies in order to be able to do exactly that, deal with the patient, not necessarily a condition, especially when we don't understand certain conditions. So
yeah, no, you're so right about that. I mean, we need the whole interdisciplinary team on the same page, because someone could go to 2 different doctors and get 2 completely different opinions. And if those doctors aren't talking to one another,
absolutely,
the patient just gets that much more frustrated and overwhelmed, and it's a lot.
Yeah.
And sometimes as a patient, I think we feel like just kind of, we get our 10 minutes and then after that, we're a burden, or they're not taking us seriously. And as sad as what you said is, like, coming into the office looking not very well put together. I mean, if that is what it takes to get their attention and get them to take you seriously, then you got to do what you got to do. And I remember Jill Osborne came on here once and said, as best you can, try not to cry during an appointment, because that's another thing that will most likely not get them to take you seriously. And that's so unfortunate, but it's the reality.
Right. And then again, people like you, thank God they exist, because we are not in a bubble. I mean, we interact with our environment, we interact with our food, we interact with all kinds of things. All of those interactions play a role. So from the very beginning, when I have to deal with a case, I will try to get out of the way as many of those parameters that might, to some extent, be controlled or being dealt with. Because at the end of the day, we don't know how to deal with interstitial cystitis, we don't know the pathogenesis. So we can at least eliminate as many of the triggers as possible. The life hopefully will be more manageable and allow more time to then find out what might be certain things that could be, I don't want to say corrected, because I don't know what I'm correcting basically, other than the fact that yes, there is a problem in the bladder. At least we know that the lining of the bladder is not falling apart necessarily, but it's got cracks, it's got problems, and then the nerves in the area are sensitized. So that much we know. We just don't know what started this process, but we certainly know what makes it worse.
Mm-hmm. Yeah, exactly. So diving into mast cells, you kind of talked about those earlier, but can you define in the simplest way possible what mast cells are?
Sure. So mast cells belong to the immune system. They do derive from the bone marrow, just like other immune cells, just like red blood cells, platelets, but it's a different lineage. So they're not the same cells. They enter the blood as precursors or progenitor cells, and they stay very little in the blood. Then they go into the tissues, and we call it, they mature, quote unquote, in the tissues. And we used to think that a mast cell is the same in all tissues, and that's clearly not the case. So you find mast cells in all tissues of the body. And what is critical is, on the one hand, you found them in areas exposed to the outside world, like your mouth, your lungs, your skin, your bladder, your gut. They're also found in the brain. In fact, we have as many mast cells in the most critical part of the brain that regulates what we call homeostasis, hypothalamus, thalamus, as we have in our skin. Yet the main trigger of the mast cell, which is immunoglobulin E and some allergen that binds to immunoglobulin E, IgE does not cross what protects the brain. It's called the blood-brain barrier. Now, the mast cell was discovered in 1887 by Dr. Paul Ehrlich. That was part of his doctoral thesis in Germany. So he was staining tissues, and he was using various dyes, and he used a dye that was blue. But when he applied the dye to certain sections of the skin and other tissues, certain cells turned violet. And he called that from the Greek, metachromasia, change in color. So he saw that those cells had all kind of little bluish violet dots. He didn't know what those dots were, but he thought that those dots contained molecules that were feeding surrounding cells. And because the Greek word for breast is masto, like mastectomy, for instance, or he called them mast cells because they thought they were feeding on the cells. He could not have been more wrong because that's not what they do, but the name survived. Interestingly enough, at about the same time, in 1901, two French scientists, Richet and Portier, were doing experiments out of the Oceanographic Museum in the Principality of Monaco, where Jacques Cousteau used to take over his expeditions. And their experiment was they collected tentacles from jellyfish, they ground them up, and the idea was they were going to inject them into dogs, and the dogs were going to be prevented from subsequent stings from the tentacles. And they had a word ready for that phenomenon. They were going to call it prophylaxis. Instead, when they re-exposed the dogs, they dropped the blood pressure, the bronchi constricted, and they died. So they changed the name to anaphylaxis. So even though the mast cells and the word anaphylaxis were coined at about the same time, around early 1900, there was no connection between the two until 1947, when histamine was discovered in the mast cells. And of course, now we know that anaphylaxis is due to the mast cells being activated. So that's the extreme. So each mast cell contains about 1,000 little granules. So it's like a soccer ball filled with about 500 ping pong balls. And each ping pong ball has about 50 molecules, histamine being one of them. When the mast cell is triggered like in anaphylaxis, it literally explodes like a hand grenade, but it doesn't die, and it releases as many as 100 molecules. But unfortunately, we only deal with one, histamine, and we give antihistamines. And in cases of asthma, we deal with a second called leukotrienes, and we give a drug called Singular. But we have no way of dealing with the other molecules. In addition to histamine, there's a unique molecule found in the mast cell granules called tryptase. It's a proteolytic enzyme, it's like a meat tenderizer. But when it's released, it can destroy tissues, and both histamine and leukotrienes and prostaglandins and tryptase are extreme sensitizers of nerve endings. In fact, about 5 years ago, my colleagues in my lab, and now have others, identified another molecule called interleukin-31. This is a cytokine, and IL-31 is much, much, much more pruritogenic, causes itching and irritation than histamine. But we don't have any drugs to deal with interleukin-31, and the list goes on. So years ago, almost 20 years ago, I had the pleasure to work with the chief of urology at New England Medical Center in Boston at that time, Dr. Granum Sant, and he brought to my attention the fact that there is this condition called interstitial cystitis, and would I be interested in studying it? So we got actually very good funding from NIH for both basic and clinical studies at that time. And we showed, as did a group in Sweden, that was about 20 years ago, that there is actually inflammation in the bladder, and I'll define that for the bladder, And the mast cells were more in number, and they were also activated in the mucosa and the detrusal muscle of the bladder. In fact, European urologists who tend to biopsy the muscle much more my US colleagues, in the US, they're afraid that might perforate the muscle and don't often do that. When they actually do that, the increase in mast cell numbers is part of the diagnosis of interstitial cystitis in Europe, while we don't use that at all in the United States. So we showed back then 3 very important findings. They have been repeated by many other colleagues, but unfortunately, no company has latched on those findings to create, hopefully, medications. Number 1 is the mast cells are greater in number, they're activated. And we showed that they release not only histamine in the bladder, or in the urine if you wish, but also inflammatory cytokines such as interleukin-1, interleukin-31, tumor necrosis factor, interleukin-6. So a number of people have shown that. What is tricky at times is that if an individual has another inflammatory disease, let's say someone has rheumatoid arthritis, chances are that some of these molecules might be found in the urine too. So therefore, that is confusing at times. We actually did these experiments using rats or mice, where we can collect actually the urine, and the urine as it's collected will frozen immediately by having the animals in cages. And clearly those animals do not have any other disease. So we know that happens, but as I said, it might be confusing either comorbidities. So that was one. The second was, we found that one molecule that is called a peptide, more specifically neuropeptide, called substance P, that has been involved in pain for many, many, many years, was actually in higher amounts in nerve endings in the bladder, and we could also pick it up in the urine. And at that time, I had the honor actually to be working with who now is a very good colleague, Dr. Susan Lehman, who was about 92 years old, and she discovered substance P. And we were very excited about the possibilities. And I will return to substance P a little later if we have time. So clearly, a molecule released from nerve endings was stimulating the bladder to induce inflammation and also act back on the nerve endings to cause pain. We know, for instance, that this substance P is very involved in herpes zoster. So in herpes zoster, as you know, we have the distribution of the nerves coming out of the spinal cord. You get blisters along those nerve endings, and the pain is associated actually with, to a large extent, substance P. And that's why many times one can use a transdermal, a patch that contains capsaicin that depletes the nerve endings of substance P. Unfortunately, we can't put that in the bladder because it will cause burning in the bladder. So otherwise, there would have been something to use. The last component is we've known from patients that emotional and physical stress can worsen symptoms. So we actually published a number of papers, and then other colleagues published it in humans as well, where we put the mice or the rats in an immobilizer, plexiglass immobilizer, and you would think that rodents like small places, they hate it. Within 15 minutes, we had symptoms equivalent to interstitial cystitis developed, such as frequency of urination and pain that we were recording. And we measured the main hormone released under stress called CRH, or corticotropin releasing hormone, and that was high in the urine as well. So we know with molecular ways that neuropeptides are released, stress hormones are released, and that they activate the mast cells, and the mast cells cause local inflammation of the bladder. That then activates nerve endings, and you get a chronic condition of hypersensitivity. It's like having phantom pain. The trigger might not be there anymore, but the nerves keep on firing pain messages. And of course, if the triggers remain, over new triggers are added, then you get basically just a cyclic reaction and there's no end to it. So we also showed early on that a number of IC patients do have allergic or atopic problems elsewhere in the body. Those would be the individuals who are even more likely to have problems in the bladder that cannot be addressed by the typical things that colleagues use. So if someone therefore has, let's say, an allergic or atopic condition, then the first thing that I would do is address that, because there are certain things we do use for atopic conditions, and clinical trials have been published, but those approaches have not been tested for interstitial cystitis. So the immediate hope is if you address those conditions that also involve mast cells, then the sort of neuroinflammation or allergic inflammation will also subside in the bladder. And then you're left with whatever symptoms are left, and then you try to address those in addition. Now, whenever I talk about mast cell related problems, I separate them in three general categories. One category is what we call primary mast cell disorders. Those are fairly rare. That would be, for instance, systemic mastocytosis, where patients have a lot of mast cells in their bone marrow. But I consider interstitial cystitis bladder mastocytosis because we have a lot of mast cells and they tend to be activated. But no one considers that as a bladder mastocytosis because only in Europe they count mast cells. The second category, large category, are the so-called exogenous or extrinsic or secondary mast cell disorders. There would be eczema of the skin, asthma, rhinitis, all the things that we know about. And then you've got the so-called idiopathic, and unfortunately, if medicine doesn't understand something, they call it idiopathic. So you might have idiopathic anaphylaxis, you might have idiopathic edema. And that's where you have mast cell activation syndrome, where it's not a typical allergy. And these patients respond, as I said earlier, to stress, to pressure, to heat, cold, all kinds of things. And in my mind, interstitial cystitis would belong in that category because we don't know the exact triggers. In addition, however, there are two other conditions we should not forget. One is histamine intolerance. That's not a mast cell related necessarily condition because histamine comes from mast cells, but it also comes from foods, getting into your territory. Mm-hmm. And there are many foods that we know are very high in histamine. So a ripe tomato, ripe avocado, spinach, eggplant, cheeses, of course, sardines, spices, other than, salt and pepper. So invariably, anytime I deal with a patient that has any mast cell related problem, including interstitial cystitis, I will say for X period of time, let's avoid those, in addition to other things that you know. There are also individuals that are intolerant to so-called phenols. So phenols are found in chocolate, in strawberries, berries, etc. There's a group, not necessarily only in interstitial cystitis, of individuals who cannot tolerate phenols, and they get very hyper. And you can be hyper in terms of how you deal with others, or your bladder can be hyper. You can run into the bathroom. Now, luckily, such problems can be identified with some gene testing. And there are many companies that do such gene testing these days. There's a company called Genomine, it's pretty good, but there are many others. So vis-a-vis the histamine part, I ask for the enzyme that breaks down histamine called diamine oxidase. If it is, so that's for histamine. If it's for phenol intolerance, there are different enzymes such as monoamine oxidase or catecholamine orthomethyltransferase, and we're looking for mutations. To make it simpler, we identify such individuals as slow metabolizers or fast metabolizers. So if you have mutations, you're likely to be a slow metabolizer. So I need to know that because at least in the case of the histamine intolerance, there are supplements where you can get the enzyme diamine oxidase and you give it to patients about 50 minutes before each meal. Histamine is a good one that comes from pork. There's one from beans, so that's more natural, if you wish, called nut or dow. But one doesn't have to be necessarily in the category of having allergies, because with my patients where the symptoms are mostly related to the bladder, and if one were to avoid such foods or get such a supplement, you might find a benefit, and then you'll know that it helps you. And these are the kind of things usually urologists, for good measure, don't deal with, because they focus only on what can be done vis-a-vis the bladder as such. Mm-hmm. And then there are molecules that could inhibit the mast cells. So if the mast cell is activated, then you have to deal with those molecules that have already been released. So if it's histamine, you give antihistamines. And we'll talk about antihistamines. My approach is, can I actually block the mast cell from not releasing any of the molecules? Because I don't know how to block the rest of the molecules. In some cases, we don't even know what is being released. And that's how we came about developing Cystoprotect, about which I'll talk in a few minutes. So the primary idea is, can we block the mast cells? Second, or maybe first, can we remove the triggers? Whether it's histamine or trigger, etc. Can we block the mast cells? If the mast cells have been activated, can we block the downstream events such as antihistamines, etc. Now, let's start from the antihistamines. I remember the first time I was invited to go to an ICA meeting 20 years ago. Unfortunately, the person inviting me has long passed, God bless her. And she actually asked me, well, I take a lot of antihistamines, and I can't go to the bathroom. And that's a major problem. If you take too much of any antihistamine, they also have what we call anticholinergic effect, and it can put you into retention. So a small amount or a reasonable amount of an antihistamine will be good, because you will block the histamine vis-a-vis any actions it might have, and it's slightly anti-having you go, if you wish. Okay? So that's good. But too much of it can block you from going. Then you could go into retention. So we've got to be aware of what we use and how much we use. Number two, we have to keep in mind combination of products. For instance, many of the so-called flavonoids, such as quercetin, curcumin, luteolin, pycnogenol, are phenolic. And I already said some individuals actually are sensitive to phenols. So you might not recognize they're all phenolic. So you might take, 500 milligrams of this, 500 milligrams of that, 500 milligrams of the other. Collectively, if they go more than about 1.5 grams or 1,500 milligrams a day, they started causing problems. For instance, all of these compounds in powder form are absorbed less than 10% from the intestine. So let's say you give someone 2,000 milligrams a day because they're not getting absorbed very well. You absorb about 200 milligrams, 1,800 milligrams will stay in your gut. That will shut down your bioflora, and you end up with dysbiosis. And now you start chasing your tail about what happened. Also, if you give too much, they can shut down liver enzymes. And if you need to take a medication that needs to be metabolized in the liver in order to act, then that medication might not be working very well. Or if you give too much of these molecules to, let's say, a young girl that enters puberty, it might change the hormone levels, because all the hormones are broken down in the liver as well. So again, too much of something, whether it's a drug or a supplement, is not necessarily good. So going back to what did we decide to do that? Well, it was obvious to me, as I'm sure to everybody, that there is some problem with the bladder lining. When you do distension, you basically expand the bladder, and usually when you expand the bladder, that's where you see microbleeds, and you call those petechiae. They call them glomerulations, and God knows why they call them that, because I don't know what it means. That's what they were seeing. So we're seeing microbleeds. What is interesting and surprised me and made me an enemy of some of my urology colleagues, back then, is they were using water. If you know, they call it hydrodistension. But water will actually burst the cells because water draws from the cells out by osmosis. And therefore, we were worried that some of the microbleeds might be due to the fact that water was used. Since then, this has changed, and a lot of colleagues, for good reason, are using either normal saline, as we call it, which is what we give intravenously to if we need to, or a glycine solution, which is neutral, and it doesn't actually change the osmotic behavior. Now, it turned out that that was an absolute requirement for doing clinical studies. You had to do actually hydrodistension, even though it's not water, as a diagnosis of interstitial cystitis. But this has been abandoned in clinical practice. Very few people do it anymore. And I want to stress that if they scope the bladder in the office without hydrodistension, it doesn't show anything. So if someone tells you, they're going there, I don't see anything, they're not going to see anything. You need to do it under either spinal or general anesthesia, which of course becomes very expensive, etc. So as you know, by definition, we pretty much say if someone has had urinary tract infection like UTA-like symptoms for 2-3 months and antibiotics don't work and the cultures are negative, you've got IC. So it's gotten to that. So going back to the bladder, we said, okay, number one, there is obviously some problem in the bladder lining. And yes, we understand that there's also a problem in the sensory nerves in the bladder. So what can we do? Well, the bladder lining is primarily made by 2 molecules that are extending from the bladder lining and keep the urine sort of at bay, if you wish. And that's chondroitin and hyaluronate. Interestingly enough, both of these molecules are found in our joints as well. That's why people get osteobiflex. It gives you, chondroitin and glucosamine, etc. So we said, why don't we just create something, obviously a supplement, that contains chondroitin and hyaluronate? That might allow the bladder lining to use those molecules to repair itself, because we're giving them the building blocks. But as long as there's inflammation, we're going to be spinning our wheels, because the inflammation will destroy the bladder lining and go on and on. So at that time, we decided to use the best known flavonoid, quercetin. Then the question was, since these are not absorbed very well from the gut, how can we increase absorption? And as you know, if you take any powder and you mix it with any oil and you shake it, you give it energy, you start creating spheres. We call them liposomes. Some spheres are bigger, some spheres are smaller, and the spheres trap inside the powder. So after testing various oils, we decided to use olive pomace oil. That means that after you take the olive oil, you're left with a pit. You squeeze the pit, you get a little thicker oil, or you can call it olive seed oil. The French have a better word, they call it olive fruit oil, because fruit sounds a little better than kernel or pomace oil. So in any event, after we tested all kinds of oils, we tried, for all the way from, primrose oil to, corn oil to whatever. It turned out that the olive pomace oil was the best and the cheapest in terms of creating a liposomal preparation that increased basically the absorption of the active ingredients by, 3 to 5 times. And that's how we created the Cystoprotect. Now, at that time, it was interesting that a company was experimenting with a very small molecule that might have allowed to cover the cracks, and that was pentosan polysulfate, or Elmiron. One of the difficulties with that drug was that it was very small, so it can be washed away very quickly, while chondroitin and hyaluronic acid are very long molecules that can kind of stick to the surface. And the second problem was, as you probably know, is that the first clinical trial that was used to obtain orphan disease status with the FDA could not be duplicated in subsequent studies. So a number of clinical studies were done, and the effect was minimal, if at all. But because it was the only thing that was prescribed, it stayed on. And I guess, if you're desperate and you have nothing else, you use that. But unfortunately, as you know, numerous studies have shown over the last 2 years, it can damage your eyes. And now there's a black box warning, maybe will be taken off the market. So going back to the Cystoprotect, a couple of open label studies were done and they were published showing benefit. And one study that was funded by the NIH was combining that along with an old antihistamine called hydroxyzine or Atarax. So hydroxyzine is a good, excellent antihistamine. It's slightly anti-anxiety, and it also, to some extent, limits your need to go to the bathroom. So you were getting 3 birds with 1 stone. Another similar study was done instead of hydroxyzine, using an antidepressant drug called amitriptyline or Elavil for exactly the same reason. It's both an antidepressant, it's an antihistamine, as well as there have been studies that can be very helpful in neuropathic pain. So most of the time, the approach had been to eliminate triggers, if you know what you're doing, eliminate or correct the diet. We can talk about acids if you want, at some point. And then try to also address the pain. So either one would give Cystoprotect with Atarax at night or with Elavil at night, not going more than about 25 milligrams at a time, because once you start pushing, both can be very sedating. And that has been pretty much what patients have been using for many years. Now, in addition, one can try to address the inflammation to some extent with other molecules. So for instance, we know that aloe has anti-inflammatory properties, and desert harvest has a wonderful aloe vera that can be used. They can be used synergistically because they work very differently anyhow. And I always say, sure, take it. In fact, we created a skin lotion called Gentle Derm that is entirely hypoallergenic, can be tolerated by people that cannot tolerate mascara on. And that lotion has aloe extract, oregano extract, olive leaf extract, chamomile extract, and oregano extract that has a molecule that is much more potent than quercetin. And unless there's an open wound, in which case one should not put anything on an open wound unless you put an antibiotic, many individuals that have either vestibulitis or vulvodynia actually use it in that area with what they say are actually useful outcomes. Let me stop there. I gave you an earful. You can ask and then I'll come back to.
Yeah, that was a lot to digest for sure. A lot of really great information. You got me caught up on the cystoscopy thing where you said that you should do it under anesthesia because you might
doesn't show anything otherwise.
I've had
unless you have a horrible ulcer, in which case it will show up. It doesn't.
Right. And so I had a cystoscopy done in office, no anesthesia or anything. It was incredibly painful and it showed nothing.
Yes.
And so they're like, there's really nothing we can do for you since you've done all the treatment options. So you're saying that it really should be done under anesthesia.
Well, yes, with a proviso. As I said, clinically, within reason, one can say, yes, you have interstitial cystitis because of what we discussed. So if one can say that and then move on to potential treatment approaches, the question is, why pay $2,000 or whatever it might cost to go under anesthesia and do that? And when they do it, unless they see ulcers, there's nothing more that you can do about the petechiae other than what we've discussed and we can continue discussing. The only time, and I stand to be corrected, I'm not a urologist, obviously, that could be useful if you see ulcers, because if you see ulcers during the cystoscopy under anesthesia, the urologist could actually laser the ulcers or might address them in some other way, because the ulcers are notoriously the worst to deal with the kind of things that you and I have been discussing. So I don't want to give the impression that by taking Elavil or hydroxyzine or Cystoprotect, ulcers will disappear. That will not happen. So from that point of view, if the pain is incredible, if there's especially blood in the urine, and you suspect an ulcer, then you should do it under spinal or general anesthesia. And I would imagine a urologist would go that route if he or she feels that way.
Mm-hmm. Yeah, and I saw that written in the updates to the American Urologic Association guidelines. So,
yeah. But I clearly will take issue with what they said to you, that an office cystoscopy doesn't show anything, therefore you don't have problem. That's just not so.
Right. Yeah. I think there's two different things that can happen there. They can either say, yeah, you have IC, but there's really nothing that we can do, or they can say your bladder looks completely normal and healthy, you don't have IC. And I've heard so many people with IC saying that happened to them.
That's totally wrong. They just don't know what they're doing, unfortunately. So
exactly. And that's one of those red flags where a doctor doesn't know what they're doing, and you should get a second opinion.
Right. One of my goals, if I can say that, as I re-enter research in this area, and as you know, there will be a symposium at the Nova Southeastern University Clearwater campus on interstitial cystitis on Saturday, March 11th. And I'll have the pleasure to have Dr. Whitmer, Dr. Evans, and Dr. Moldwin actually join us in lecturing there. Is also to brainstorm what can we do research-wise to move the field forward, because it has stalemated over the years. One possibility that we are all very interested in is, can we pick up any biomarkers in the urine that have not been thought about or tested in the past, that at least might give us a handle to say, well, look, these are high, very high probability you got IC, because that would be wonderful. It could be a spot urine or maybe 24-hour collection urine. It would be easy, because I don't think we'll score by testing anything in the blood. That's number one. Number two, there may be real possibilities. For instance, I mentioned substance P earlier. Substance P activates cells by binding to a receptor on the surface called NK1 or neurokinin 1. Well, there is a drug that's been around for 10 years that was developed to block NK1 receptors, and it is used for nausea and vomiting, especially related to cancer. Well, it wouldn't be difficult to do a clinical study and use this available drug, since there's plenty of evidence that substance P is high in the bladder, and see if it actually helps. But a urologist will have to do that. I cannot do that. So one of the thoughts might be, can we potentially write to the Department of Defense that every year has announcements for research for IC, and with one of my 3 colleagues or any other colleague, set up a little clinical study. This is an approved drug. It's not very expensive. Maybe even the company might be interested in supporting. So these are the kind of things that I'd like to come out of this symposium, not necessarily inform patients who are already pretty informed, actually more so than many urologists, but also the urologist. So I sent out, for instance, 300 invitations to urologists in all over Florida. So far, only one has indicated he's willing to come.